Good morning, everyone. This is the head and neck session, in case you're unaware. I'm Jim Rocco. I'm a head and neck surgeon coming from Ohio State, and I'll be the moderator of this session. David Rabin was supposed to be my co-partner here, but he had some circumstances and he couldn't make it, so his apologies. So our first thing we'd like to talk about is a debate between two very informed individuals on radiation de-escalation in HPV-related head and neck cancer. I think we all know that, how to treat HPV-related head and neck cancer is evolving. These patients do well, but not everyone does well. I think we're all looking for insights on how to approach this. So the rules of our engagement. Certainly, we're going to have a debate-style format. Each speaker gets 30 minutes to stake out their position. Each speaker is allowed a 5-minute rebuttal. It can be very friendly or a joint rebuttal. There'll be 15 minutes allotted to questions at the end with an open microphone, and we really encourage the audience to ask the questions that they want to ask and to ask the tough questions. So we appreciate your efforts. So our contestants, who are they? Well, we have Dr. Sue Yum from UCSF, who I know a little bit. I hope she doesn't kill me for that picture, but that's the best I could do, like kind of on the plane real fast as I thought about this. Yeah, they're pretty muscular, those legs, though. And I did try to look for a female doll, but it took me to these sites that no one should ever really look at. That's all I have to say. So I knew that would not go over well. So anyway, so she's an associate professor and director of head and neck and thoracic radiotherapy at UCSF. She received her MD and PhD training at the University of Pennsylvania and her medicine and radiation oncology training from MD Anderson Cancer Center. She's the author of numerous manuscripts and book chapters. She has a number of special interests, including cooperative group trials, scientific publications, T3 translational science. She's also a member of the Head and Neck Cancer Publications, Radiation Oncology, and Patient-Centered Outcomes Research Committee at the NRG Cooperative Group. She is the Head and Neck Section Editor for the International Journal of Radiation Oncology, Biology, and Physics. She's a member of the NCCN Guideline Panel, Head and Neck Cancers, and chair of the ACR Appropriateness Criteria Expert Panel on Radiation Oncology, Head and Neck Cancer. So certainly any feedback she gets today, she seems to be part of a committee that could move that forward. Our contestant, David Brizel from Duke, is the Leonard Prosnitz Professor of Radiation Oncology and co-director of Duke Cancer Institute Head and Neck Cancer Program. He received his MD from Northwestern University and his radiation oncology training at the Harvard Joint Center for Radiation Therapy. The author of over 100 manuscripts and numerous book chapters, he has also served as a member of the NIH Radiation Therapeutics and Biologics Study Section, and as the NCCN Head and Neck Cancer Treatment Guidelines Committee as well. He's also currently a member of the NCCN Head and Neck Radiotherapy and Surgical Guidelines Subcommittee. He's made seminal contributions as the PI of institutional and multinational phase 3 trials that demonstrate the superiority of concurrent chemoradiotherapy over radiotherapy alone in locally advanced head and neck cancer, and as well as studies that have shown the benefit of amifostine and salivary gland radiation-induced damage. So let's get ready to rumble. We can have our first speaker.
I have a couple disclosures real quick. I get research support from Genentech and NCCN, and I received some royalties from Up to Date, but that does not oblige me in any way to Dr. Brizel. So I don't know how many of you read Wallace Stevens, but I have a little illusion here. 13 Ways of Staring Down Dave Brizel, or How I Learned to Stop Worrying and Love Radiation De-Escalation with HPV. So principle number one, up until now, the machine we've been using in head and neck cancer has been Escalation. And this is one of my favorite cartoons, which is, I call the more machine. More, 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 more. Every button you push, it says more. And this is essentially what we've been doing in head and neck cancer for a good, 10, 15 years. And this is the brief and tortured history of head and neck escalation therapy. The additional chemotherapy that was given with radiation in the early 2000s produced a success, and we'll talk about that, in a mixed population of advanced smoking-dominated head and neck cancer patients. But if you look at recent head and neck cancer trials testing quote-unquote escalation or quote-unquote intensification, interesting that these terms have only now taken currency within the literature because we've only just now realized that these are escalation or intensifications, have failed to meet their statistical endpoints because of the emergence of this entity defined around HPV. So the paradigm of intensification went on throughout the 2000s. We can start with the intergroup study, which was published in 2000, 70 gray versus 70 gray plus cisplatin, then RTOG 0129, 70 gray and cisplatin. Now we're accelerating radiation in the other arm. 0522, now we're accelerating radiation, plus we're adding cetuximab, intensification. And after the intergroup trial, none of these other trials, in addition to numerous other trials that I'm not listing here, met their endpoints because they were essentially washed out by the huge prevalence of oropharyngeal HPV-dominated cancers in those subsets. And in RTOG 1016 and 002, which have been just recently opened, closed in the case of 1016 and just opened in the case of HN002, now we're starting to talk just now about de-intensification. So the point of this brief review is that thoughtful escalation is important for most head and neck cancers. Let's put that out there as our starting principle, about 80%, but not for HPV-driven oropharyngeal cancers. So in circa 2000 to 2003, as I just showed you, the intergroup trial and the GORTEC trial came out. And as you can see, just looking at that overall survival line down there, they did produce statistically significant, important differences in survival. But note that the survivals overall are in the 20s and 30s. And that's not what we see in the oropharyngeal cancer population we're treating now, right? And then you look at the kinds of patients that were included in these trials, stage 3 and 4. Okay, fine, stage 3 and 4. But in circa 2000-2003, when these studies were published, 86 or 85% of these patients had extremely locally advanced tumors, and while the majority of them were oropharynx in the intergroup trial, they were mostly T4 or N3. Again, not really what we're seeing in our populations. And then, of course, you know, the cisplatin that was given in that trial and the cisplatin 5-FU that was given in the GORTEC trial did produce benefits in survival we've seen, and the benefits of concurrent chemoradiation were confirmed in the mock meta-analysis, mostly driven by the use of platinum-based agents, as was further analyzed. But what did we sacrifice in the course of moving all of our head and neck advanced stage patients to chemoradiotherapy? This is an analysis of 5 RTOG studies, so prospective solid data that was analyzed by Andy Trotti and colleagues, looking at the burden of what he called the acute toxicity score, or the T-score. And as you can see here, on the far left is the RT alone column that I've labeled down there. And then you have a number of platforms, all essentially platinum-based chemoradiotherapy. And if you're not able to see the axis there, raising the T-score by 300, up to 300 or 450%. So 3 to 4.5 times the toxicity with chemoradiation. And we've accepted that as the current standard of care based on those older trials. And I will note to you that my own institution is here in this grid. UCSF is right there. And we've done it just like everyone else, and that we now achieve impressive, and I want to acknowledge this, very impressive overall survival with the use of mostly IMRT and platinum-based chemoradiotherapy platforms. So, you know, PFS is of mid to high 80s, which is great. I'm aware in my own practice, and I'm sure many of you are too, that while the majority of our patients do quite well with this platform, there are patients who experience long-term morbidity, including swallowing dysfunction, strictures, xerostomia, dental effects, osteoid necrosis, carotid stenosis, and I become increasingly concerned about this because in my practice, these HPV patients tend to be younger, sometimes a decade younger than what you would expect in a head and neck cancer population. And so these are things that could build up over time, and we haven't quite seen the full onslaught of that yet, but it's certainly happening in certain patients, and it's out there. So my conclusion here is there's a relatively weak justification for current intensified regimens. Most of the basis of this is from older meta-analysis and clinical trials that I consider essentially non-relevant to this specific HPV-positive population. And the other thing is that if you look in some of the literature, really toxicity and quality of life have not been considered important co-primary or secondary endpoints. The real imperative has been to improve survival, and that's consistent with what patients have wanted in the past based on surveys. Here are two examples of what I call the more machine. Just picking a little bit here on the medical oncology colleagues, two induction trials that opened to great fanfare, essentially changed the NCCN guidelines to incorporate induction as part of the standard of care because there was so much excitement before these trials were even run, both comparing induction followed by chemoradiation platforms versus chemoradiation alone. This is the Paradigm trial, which had TPF induction followed by carboplatin and radiation compared to cisplatin radiation alone. And as you can see down there, the 3-year overall survival was not different at all. And in fact, the standard arm did better. And in the DECIDE trial, which was very similar, another TPF-based induction regimen followed by a concurrent chemoradiation of a somewhat unique nature done in Chicago versus concurrent chemoradiation alone. And again, as you see here, overall survival is not significantly different. In fact, with the standard arm even doing a little bit better. And again, 60% in the DECIDE trial had oropharyngeal cancer. So the majority of patients in these trials had oropharyngeal cancer. We know that about 80% of those were HPV positive driven oropharyngeal cancers, and neither of these trials produced an advantage. So yet another example of how intensification in this population in unselected oropharyngeal cancers does not produce further benefit. Okay, so number 2, oropharyngeal cancer in this day and age is no longer one disease, but many diseases. And yet in 2015, we continue to treat advanced oropharyngeal cancers pretty much all the same, despite the fact that since 2000, we've known that this HPV subset can be broken out with a very distinct clinical profile. I'll just run through the checklist here. Tonsil, base of tongue, socioeconomic status is different, related to oral sex and other sexual behaviors, younger, Caucasian, male, non-smoking, exceptionally responsive to many different kinds of treatments, probably at least 70% of tonsil and base of tongue cancers with a rising incidence. And P16, as many of you are probably familiar, is the cheap and readily available $50 stain that has now been taken on as the surrogate marker to correlate with HPV. So P16 immunohistochemical staining has about a 90% correlation with HPV DNA integration. So it's pretty good, and it's widely available, and it's easy to use, and it's easy to read. Now, when you look at some reanalyses of prospective data, such as this one from 0129, that RTOG trial, you'll see that the survival differences in the HPV positive population and the HPV negative population are very different. And I'm sure many of you have seen this slide because it's been repeated in many oropharyngeal cancer presentations. And what's also interesting is this recent study of 0129 and 0522 prospective data was looking at what happens to HPV oropharyngeal cancer patients after they recur. And here's the difference between P16 positive versus P16 negative patients, whether they had local regional progression, whether they had distant metastases, whether they had salvage surgery, whether they had no salvage surgery, they always still survive longer. So if the prognosis is this different based on one biomarker, should we consider all oropharyngeal cancer to be the same disease? And why are we treating them all the same just because they're advanced stage? So my third point here is de-escalation is not new. It just means not escalating. If you look in the standard NCCN guidelines, actually for T1, T2, N0, N1, it is codified in the guidelines that you should attempt to use a single modality if possible, namely definitive RT, possibly surgery with some adjuvant tailored therapy, and only for T2 N1 at a lower level of recommendation is concurrent chemotherapy advised. So 2B, not 2A, which is the standard recommendation for things that are not noted specifically to be different, but 2B, so a slightly lower recommendation. And that is based on quite a long clinical experience, including the MD Anderson experience, which for many years has utilized 66 gray and 30 fractions as a standard treatment for T1, T2 oropharyngeal cancers, even sometimes despite a nominal stage of 3 and 4. And what's interesting is this is a graph that's taken from one of the large oropharyngeal series publications from that institution. And if you look here at the T1 to T2 categories, there was no benefit from current chemotherapy added to the radiotherapy platform in these cancers. And in fact, the T1 to T2 line, which is the blue line on top, did better. So there's no benefit in local regional control from the addition of concurrent chemotherapy in these small primary cancers. And that was confirmed in prospective data in RTOG 0022, an early trial of IMRT feasibility. And in this trial, again, 66 gray and 30 fractions, note not selected for HPV, not selected for smoking, achieved a 2-year local regional control rate of 91% at 2 years. And interestingly, in this study, all cases of local regional failure, metastases, or second primary, basically anything bad that happened only happened in the patients who were current or former smokers. All right, point 4. So don't get all excited just because I mentioned Canada. I know how exciting that can be. Canadians are not dummies. Canadians are not liars. Everyone stay calm. At Princess Margaret Hospital in Canada, they have published their regimens of radiation therapy alone. Radiation therapy for HPV-related oropharyngeal cancer, radiation therapy as a monotherapy platform, and one of the most common regimens they use is 60 gray, delivered in an accelerated manner, slightly larger fractions, over 5 weeks. That's one of their most common regimens. And if you look here, when they analyze by P16 positive versus P16 negative, no great surprise. Their data confirms what we've seen in all these other data sets. P16 does better. And specifically when they look at radiotherapy alone for P16 positive disease with less than 10 pack years of smoking, achieving excellent, outstanding local regional control and PFS and distant control as well. So these patients don't metastasize, they have long overall survival, they have good local and regional control with radiotherapy alone. This is an Ontario-based study, population-based study in the province of Ontario in Canada. And what they did was they classified the patients according to center by high chemotherapy use or low chemotherapy use. And when they compared all the patients, they found that only the N3 patients within the entire province of Ontario were doing better. So in other words, the nodal staging had little impact on the overall survival. And here is the comparison of those high chemotherapy using centers versus the low chemotherapy using centers. And essentially the implication here from this population-based study is that the addition of chemotherapy in Ontario, specifically for oropharyngeal cancer patients in 2003 and 2004, made no difference in survival. So we know with some certainty which patients we might want to select for de-escalation. We talked a little bit about the ARTOGI 0129 trial, which was cisplatin and standard radiation versus cisplatin and accelerated radiation. But the important thing, probably the most important thing we learned from that trial, was the recursive partitioning analysis that was published under Dr. Ng and by Dr. Ng and colleagues, looking at which patients you could break out of this large group of prospectively followed patients who did the best. And as you see here, all the patients who had HPV disease and had less than 10 pack years of smoking fell into the category of low risk. That means low risk for death. Maybe if you had a lot more smoking or you had a higher nodal burden, you might go into intermediate risk. But everybody who had HPV positive tumors and a low smoking history was at low risk for death. And the survival of these different risk classifications breaks out in a very dramatic manner, just showing you that biology dictates the outcome here much more in some ways than minor treatment variations. The outcomes for P16 positive oropharyngeal cancer from Canada confirm the same. This is a very similar breakdown of their treated oropharyngeal population, as you can see here. In the lowest risk for recurrence in T1 to T3 disease, the local regional control is 95%. And only when you get into N3 disease, like big disease, T4 disease, big disease, does your local regional recurrence drop down to 82%. But that's still pretty phenomenal, because remember what we just talked about in the intergroup and GORTEC trials, T4 and N3 disease, and remember those survivals were, what, 50% lower than this. So if you have HPV positive disease, even with huge nodal burden or primary burden, you can still actually get a decent local regional control. All right, so how does that help us select out which patients we might think don't need to be intensified? That was confirmed in ECOG 1308. So this is an interesting trial utilizing an induction chemotherapy strategy followed by clinical reassessment. And in the patients who achieved a clinical, what was called a clinical complete response, they got 54 gray with cetuximab. Right, 54 gray. And those who got a partial response or something else got 70 gray with cetuximab. And the 1 and 2 year results for PFS come out about, in the end, about in the mid-80s, which is pretty impressive. Basically, that slide shows that the low dose arm didn't have different outcomes than the standard arm. So those patients who got a CR and went on to 54 gray were able to achieve similar outcomes to the other arm. And at the 2 year primary endpoint, the PFS, progression-free survival, was 84%. which was just below what the statistical endpoint was that they had marked out, but it was still pretty good considering it's in the mid-80s. And what's really interesting about this trial to me, more than anything else, is that when they analyzed by subset, the patients who had less than 10 pack years of smoking, T1 to 3 disease, N0 to N2B disease, achieved a 96% two-year PFS and overall survival, okay, in the low-dose arm. And that's just a slide showing you that result. So clinical selection of patients for a D-intense, I just want to emphasize that's an experimental trial, but the important thing about that is what we're talking about in terms of selection. So numerous studies now support this clinical profile that consistently achieves excellent outcomes: P16 positive, oropharyngeal cancer, minimal smoking history, non-bulky primary, non-extensive pattern of disease spread, and essentially all approaches in this population have been impressive. Now, I just want to change the tone here a little bit. I actually reject this proposition. I don't think we should de-escalate as a matter of, not yet. I don't think we should de-escalate as a matter of course. I actually don't. I don't de-escalate in my own practice. But why would we stop studying de-escalation? And in fact, we can't. It's already happened. So here's the dealer's choice study, what I call the dealer's choice study, because they dealer's choice for any type of radiation you want to give. This is the Bonner trial that was published in New England Journal of Medicine, basically RT alone versus RT cetuximab. Again, any kind of radiation, stage 3 and 4 disease, and as we all are familiar with, the radiotherapy plus cetuximab produced a significant local regional control and survival benefits, which led to the establishment of 1016 phase 3 trial. So this is the exciting trial, head-to-head trial, RT cisplatin versus RT cetuximab, just closed, 1,000 patients, huge trial. The patients had to have HPV positive disease or P16 positive disease, but HPV confirmed as well to enroll on this study. And we're going to find out those results as they mature. But that has just closed, and they expect in this trial of 834 analyzable patients that they will see 45 events. So the train has left. It's not a question of studying de-escalation. You're either on the train or you're the guy running after the train. And these are the other studies that are going on right now in terms of non-intensification, okay? And I'm just listing them here for you so you can see the huge number of things that are happening all around the country. We have studies that are giving 60 gray with concurrent low-dose cisplatin. We have studies that are giving specific low-dose radiation to different parts of the sensitive swallowing structures. We have many studies that are trying induction strategies similar to the ECOG 1308. I think Dr. Brizel and I both have some feelings about that, which we can share with you later. We have studies that are looking at different scientific questions, dissecting, imaging to find out which patients respond to lower dose. We have one study at Davis that's, I think, going to close this year and finish out their analyses with carboplatin paclitaxel and 60 gray. And here are some new studies that have just come onto the scene. Dana-Farber is running an induction study with two different kinds of induction followed by chemoradiation or radiation, kind of complicated. There's another study with induction with an everolimus experimental agent in the induction, followed by standard or low-dose RT. There's a Mount Sinai study randomizing 2-to-1 to 56 gray versus 70 gray. There are 2 studies that are replicating the 1016 design with 70 gray with cis versus cetuximab. So de-intensification is happening. NRG HN002, this is the study that has just opened with the NRG. There are currently about 15 patients that have enrolled, and enrollment's going up every month. Oropharyngeal squamous cell carcinoma, less than 10 pack year history, and I will just point out to you the selection criteria here, which are very carefully thought through. T1 to T2 up to N2B, T3 up to N2B, excluding T4, excluding N2C, excluding N3. It has central histology review. There's actually a control for whether you're treating bilaterally, unilaterally, because this is the first trial that's going to do that to try to analyze the toxicity. I will give a nod to Dr. Brizel on that. And there are 2 arms in the study, 60 gray and 6 weeks with weekly cisplatin at 40 milligrams per meter squared versus 60 gray of XRT out 5 weeks, similar in terms of the overall treatment time package to the Princess Margaret designs. This is just a schema showing you how the dosing is done with 60 gray to the GTV, the primary in the nodes, and then 54 gray to the involved nodal fields with an option to do elective treatment to 48 gray. All right, 7. The surgeons are showing more resolve to not escalate than the radiation oncologist, all right? So the moderator is a surgeon, just pointing that out, and he's on my side. I reject the proposition on the second count. I am actually a de-escalation agnostic. What I want is for my patients to live long, healthy, happy lives. See how happy he is? There are many forms of de-escalation, and they cannot all be wrong, all right? So tonsillectomy, this was actually not a new concept either. I told you de-escalation is new. Well, this started in the 1st century BC, and the tonsils were loosened by scraping around them with a blunt hook and then torn out with a finger. And vinegar and milk were used for postoperative hemostasis, although there was an option to use frog fat as well. So transoral laser microsurgery or transoral robotic surgery has produced pretty impressive results in retrospective, heterogeneous, uncontrolled series, all right, with overall survivals in the mid-80s, pretty acceptable. And that has led to the development of the ECOG 3311 P16 trial with tailored adjuvant therapy. This is my term. I call it tailored adjuvant because you are going to get some adjuvant, but it will be tailored. It's not an automatic de-escalation, so don't let people tell you that. It is selected. You'll notice that the selection criteria are very similar to HN002. In fact, that was somewhat intentional. T1 to 3 and 1 to N2B, and you get radiation therapy, or for high risk, you can go up as high. So you can go as low as 50 gray and 25 fractions, or you can go as high as 66 gray plus weekly cisplatin. All right, so there's a little bit of a gamble in there. But the issue here is that of course, you have the addition of the transoral resection or the laser surgery in addition, which may or may not enhance the toxicity. So point 8, what things are called affects how you think about them. So I have a question for everyone in the audience, and I want you to just take a second and think about this. How would you feel about escalating therapy on a stage 1 cancer? All right? And I want you to consider that about half of P16 positive oropharyngeal cancers may about to be reclassified as stage 1. So here is a proposed staging system, somewhat coming out of the Canadian experience, proposing possibly that there could be a different type of prognostic classification looking at, oh wow, ding, 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 T1 to 3, and 0 up to N2C, okay, up to N2C, pack years less than 20, all right, not 10, but 20. And these patients, if you look at that adjusted survival probability, achieve really excellent survival. And if the prognosis is that different, then the staging perhaps should be different. And if you follow that logic out, we would potentially de-intensify on stage 1 patients and intensify on the other patients. And the stage 1 patients probably comprise about half of the eligible HPV population that entered 1016. All right, so that's the 1016 population that closed. Then you have the ECOG 1308 population that we talked about with the induction trial. Then you have ECOG 3311, the surgical trial. Then you have HN002, which is the radiation 60 gray trial. And then for everybody else, we've got to figure out something different. So we really need some more people to work on the other stuff. So who in their right mind would intensify on a stage 1 cancer? Just a question. We cannot let fear drive us into hurting our patients. And I will say to you as a heartfelt admission at this moment on the podium that this has been a struggle for me as well. But my question, which I've asked myself many times and asked my own colleagues, is why are we less frightened by escalation of therapy? Why do we consider it acceptable and okay that patients take on higher risks of toxicity and death? Why are we more afraid of that, of de-escalation, than escalation? We should be afraid of both. And I want to tell you that patients are afraid of escalation. They increasingly value their quality of life. So this is a recent German study, and I want to point out recent because priorities have changed over the decades. Recent German study looking at the 5 top-ranked priorities of head and neck cancer patients, 57% of whom in this study had oral or oropharyngeal cancer. For 42% of those populations, their top 5 priorities did not include the statement, I survived the cancer. They included things like, I can carry out my daily life tasks, I can breathe well, I don't have pain, I can eat and drink. My costs, my expenses will be covered from combating this cancer, okay? That's a powerful statement because that's very different than what we saw a couple decades ago in similar surveys. Oropharyngeal cancer treatment in the future will need to incorporate, this is my personal belief, greater understanding of patient priorities, shared decision-making, and calculated trade-offs. And my personal belief is that the future will be a landscape, not a single choice, but a landscape. And decision-making will involve your treating center's expertise, the relative therapeutic efficacy, and the long-term sequelae of various different treatments for various different classifications of this disease that is breaking down into so many different subsets. So we have induction chemotherapy, followed by de-intensified bioradiotherapy, or possibly even radiotherapy alone. That is pretty much here now. We have radiation alone, like I showed you. That is pretty much here now. We have bioradiotherapy, like the cetuximab stuff, the TROG trial that's developing, the deescalate, that's kind of here now. And emerging, we have ECOG 3311 with the addition of a surgery up front, and we have de-intensified chemoradiation with a variety of phase 2s and NRG HN002. So openness to paradigms is the only way you learn. And I'm going to unfairly quote from Dr. Brizel, who said to me at the time that we opened 002, what you learn from the study will be more important than the study itself. We can't learn if we don't try. So the choice is yours. We may not be ready to de-intensify as a matter of course, but very soon we will be. And data now supports the efficacy of standard radiation therapy alone. Data is emerging around radiation therapy with cetuximab, induction concurrent de-intensification approaches, transoral surgery with tailored adjuvant therapy in, important, appropriately selected patients. At present, clinically based patient selection is robust enough, I'm not saying it's the ultimate thing, but is robust enough for responsible use of de-intensification strategies. Thank you.
Good morning. Appreciate the opportunity to be here, and one of the advantages of speaking second is that quite often the first speaker does a lot of your work for you. And I just want to compliment Dr. Yom on a very thoughtful, fantastic talk. I found it interesting the manner in which she rejected the proposition, that she explicitly rejected the proposition that she was asked to speak about. And that made me feel a little bit better as I prepared my comments. And I think that I'm actually going to show a lot of the same slides that she did. And that has nothing to do with the fact that we had dinner together last night. But just to show slightly different emphasis on some of the same points. And then when we get into our rebuttal discussion, I think that we can have an interesting time. So I have some of the same disclosures. And you've already heard some of this, but again, I think it's important enough that, as the old Latin saying goes, repetitio est modus studiorum. So we will go over epidemiology and prognosis of this disease, spend a little time looking at the standard treatment strategies, and I think we all need to consider in this disease, what is the standard treatment strategy? In fact, is there a standard treatment strategy, or is it a landscape, as we've heard? And again, the proposition was radiation de-escalation, and I'm going to spend a good bit of time on what I call mission creep for chemotherapy, and try to address the issue that this isn't just about radiation de-escalation. Radiation isn't the only boogeyman in the room, and show some, again, similar slides that Sue showed in terms of ongoing efforts, and try to provoke us to think and discuss. Me? Provocative? What? So this is a really important paper that was published a few years back by the Hopkins group. And what they did was they went back to the SEER database and obtained tissue specimens. And they looked at, actually, God has a sense of humor, and I have some xerostomia right now. Could I have a glass of water, Jim? Only to a head and neck person, right? So the, I don't know, is there a pointer here or not? There is on the That's backwards. Anyway, the yellow curve that says 2010 in the left-hand panel, and it's the yellow curve going down in the right-hand panel, shows what's happening with cervix cancer, I guess it doesn't really matter because I'm not going to be able to aim it, so it doesn't matter, thank you. So what we see is over a period of several decades that the incidence of cervix cancer is steadily declining, while the incidence of oropharynx cancer, predominantly in men, is increasing. And on the right-hand side, if you look at the absolute number of cases, around 2010, the number of oropharynx cancer cases in the United States eclipsed the number of cervix cancer cases. And the projections are that over the coming years that that's not going to stop, that difference is going to get greater and greater. Cervix is going down, oropharynx is going up and up and up, and is rapidly becoming the most prevalent type of head and neck cancer that we see in the United States. And again, as I just said, if we look on the right-hand panel at the absolute number of cases, oropharynx cancer is becoming, if it hasn't already become, the most prevalent type of head and neck cancer. And again, over the next 15 years or so, it is projected that difference will get only greater with no leveling off. And as we see for larynx and other types of head and neck cancer, those numbers are actually going down. They're static to going down, reflecting the decreased use of tobacco in the population. And so we're really talking about different diseases. Head and neck cancer is no longer a monomorphic disease. And I think most of us from our training grew up with the left-hand stereotype of head and neck cancer. It was caused by tobacco and it was promoted by alcohol, whereas contemporary HPV is promoted by alcohol and caused by other things. It's important to remember, as we've already heard, and we'll go over again, that HPV-driven oropharynx cancer has a more favorable prognosis. And these are data from a single-arm study done at the University of Michigan, where patients had stage 3-4 oropharynx carcinoma. They received 1 cycle of induction chemotherapy, and if they had a favorable response, they went on to a relatively standard chemoradiation platform, and if they did not, they went on to resection, very similar to the old VA larynx trial. And they did some interesting tissue analyses. They looked at gene copy for HPV-16, which is the most common strain of the virus that causes oropharyngeal cancer. And what you can see on the right-hand side is that in terms of cause-specific survival, that the patients who had the highest gene copy number had the most favorable prognosis, and those who had no HPV gene copy, the gray curve, had the worst prognosis. So that was for the Michigan induction chemoradiation platform. But if we go back to the Hopkins study of the SEER database, and we look on the left-hand side, it's very clear that all HPV-positive patients have a more favorable prognosis. The SEER database that they looked at includes patients who received all different kinds of treatment. So some patients who got surgical treatment, patients who got single-arm or single-modality radiation, patients who got chemoradiation. And the right-hand panel of this slide, to me, provides some of the most sobering data of all, or it's what I like to call the "we aren't as good as we think we are" phenomenon. Namely, if you look at the very top, oropharyngeal cancers in SEER, by decade, you see a very impressive increase in median survival from decade to decade. And this coincides time-wise with the initial investigation and subsequent incorporation of concurrent chemoradiation into the standard non-surgical treatment paradigm. What you also see, though, and you see if you go down to HPV positive, you see the same phenomenon accentuated a little bit more. But if you then look at the very bottom of that slide where it's HPV negative, you see no change whatsoever. Okay, no change whatsoever. That's very sobering because, as we have heard from Dr. Yom and as you're hearing from me, over time, we have seen an evolution of head and neck cancer from the tobacco-driven disease to the HPV-driven disease. So at the same time that we've been collectively patting ourselves on the back for developing concurrent chemoradiation as a more effective treatment, the disease has changed. So we're left with the conundrum, did the treatment make a difference, or did we just start treating a more treatable disease? Now, as Sue showed us here from RTOG 0129, there is a distinct difference in outcome in patients who are getting concurrent chemoradiation as a function of whether the disease was HPV-driven or non-HPV-driven. So this effect is seen in patients treated with concurrent chemoradiation. It's also been observed in patients treated with sequential chemoradiation. This is the Dana-Farber trial, TAX-324, which compared two different regimens of induction chemotherapy followed by concurrent chemoradiation. And again, huge difference in survival. The two different arms were lumped together for this analysis. I've never seen a p-value of 10 to the minus 8 out to 8 decimal points, but the point is we now see from 0129 that HPV does better with concurrent chemoradiation, and then as we escalate the intensity of therapy, you see the same thing with induction followed by concurrent chemoradiation. But we also see it in patients who are treated with radiotherapy alone, and this is from the Danish Head and Neck Cancer Group. So these are just, Sue showed you a much more comprehensive listing of different trials, and what I'm doing is just showing you three, I think, prototypical trials that illustrate the point that the favorable prognosis for HPV-driven disease is independent of the treatment platform that's used for these patients. And so it really does bring in the issue of treatment morbidity, which, again, as you heard a few minutes ago, is really becoming more and more important in our decision-making process. And as we decide what treatment a patient, what we would recommend for treatment for our patients, I think it's mandatory that we ask ourselves the question, are we doing something for our patients or are we doing something to our patients? What do I mean by that? Well, let's go back again. Concurrent chemoradiation has been adopted as the standard of care, and this is from an update of the meta-analysis showing from 20,000 patients in multiple randomized trials that there is a long-term, very real survival advantage associated with giving concurrent chemotherapy in advanced head and neck cancer. And the magnitude of this benefit is arguably the same, if not greater, than what we see for giving adjuvant chemotherapy to women with node-negative breast cancer, which is done routinely. But I think that what's really more important is not this, but what it doesn't tell us. And I think it's incumbent upon us to remember that standard of care is not the same thing as best practice. Standard of care is the bottom, it's the baseline. Okay, standard of care is not necessarily what should be offered to every patient. And it brings us to the term mission creep, which was originally coined in 1993 to both in the Washington Post and New York Times, reflecting our misguided efforts in Somalia that led to the incident that most of us know as Black Hawk Down. Expanding a mission or project beyond the original goals after the prototypical index efforts have been successful. And it's not a good thing because it brings us, it can lead to hubris and allow us to become more and more ambitious until the whole thing comes tumbling down. So, Sue showed you this, and it very clearly points out that when you add chemotherapy to radiation, that there is more morbidity, and it's not just acute morbidity, it's not just more mucositis, it's late toxicity. This is an old slide from an old study, but I think it really points out the fact that if you look at the bottom, that you can cure these patients and their treatment remains a gift that can keep on giving. And my point is, it's not just about the radiation, okay? The radiation in these two arms was the same. So we got in this trial a marginal benefit, real but marginal benefit from adding chemotherapy. These were patients with very advanced stage disease. And in this day and age, if you think back to the quality of life slide that we saw in the previous, in Sue's talk, there are many patients who would not be willing to make this trade-off. It's not just about the radiation. And again, this is the slide from Soren Benson and Andy Trotty. She showed you the one from Andy Trotty and Soren Benson, but so same basic data. And I'm illustrating it a little bit differently. But in essence, the point I want to make, if you go, you can see the red stick figures connecting bars on the right and left side. This is RTOG 9111, which was a 3-arm randomized trial comparing for larynx preservation, advanced stage disease, comparing radiotherapy alone on the left-hand side versus induction chemotherapy followed by radiation or concurrent chemoradiation. And as you heard previously, the increase in toxicity, there's actually about a 4-fold increase in overall toxicity associated with the administration of chemotherapy, whether it's induction or whether it's concurrent. The radiotherapy was the same in both arms. So an improvement in larynx preservation associated with the administration of chemotherapy, but at a very, very significant cost to the patient. And now I want to turn our attention. We've established that if you keep the radiation constant and you escalate therapy by giving more chemotherapy, the survival advantage that you get for all comers is real but modest. The toxicity increase that you get is real and large, and that's for patients with advanced stage disease. Now let's come back to the HPV-driven oropharynx cancer. These are slightly more recent data from the Princess Margaret, I think, that complement what Sue showed us a few minutes ago, and it's the fact that this is conventional AJCC staging in oropharynx cancer. The PMH group looked at 573 HPV positive patients and a smaller number of HPV negative patients. And I'll just in the interest of time tell you that for the HPV negative patients, the tobacco-driven patients, that the conventional stage 1, 2, 3, 4 AJCC paradigm segregated out 4 different prognostic groups quite nicely. And for the HPV positive patients, you can see here that it doesn't work at all. Okay? Stage 1, 2, 3, and 4, there's not very much difference in outcome. So we're now facing the problem of how do we identify patients who might be more or less appropriate for an intensification scheme or a de-intensification scheme. And again, this is where I think that we get into the issue of mission creep and using things for purposes that are that they weren't really ever initially intended. And as we heard a little bit, and I want to amplify on, the trials that were designed to initially study concurrent chemoradiation and even induction chemotherapy were for patients who did not have little T-stage disease, okay? They weren't designed for the T1 and T2 patients. And in fact, most of these studies, including ours, also did not allow patients with T1N1 disease or T2N1 disease to be enrolled onto studies, and to some extent even the T1N2s. These studies were designed for patients who presented with massive disease, T3 and T4, where the concern was attaining local control, or for N3 disease, where the concern was attaining regional control. And if you go back and you read these studies, that's what you will see constitutes the majority of the patient study population. Our trial, which was published in 1998, 75% of the patients on the study had T3 and T4 disease, and over 50% of them had extensive N2B or N3 disease. And what has happened, and I think that this reflects to a certain extent a fundamental difference between us as radiation oncologists and some of our medical oncology colleagues, is that we tend to look at things as T, this, and that, and we tend to be splitters, and there's a greater tendency for them to be lumpers, and to call everything stage 3 and stage 4, oh, it's advanced stage disease, we need to give chemoradiation, and then suddenly you're into the problems that I showed you a few slides back, okay? The chemotherapy is now being used routinely for settings in which it was never intended. And so that's going on at the same time that we're seeing a larger and larger proportion of patients with a disease that has a much more favorable prognosis that's independent of treatment. So we really need to be asking questions, and I'm getting away from radiation de-escalation and saying, who are good candidates for de-escalation, period? And equally important, who are the poor candidates? And then what's the best strategy? And again, we've seen from the RTOG 0129 that smoking is exerts a detrimental effect on outcome in HPV-driven oropharynx cancer. The more you smoke, the worse it gets. And we heard from Sue that the cutoff point in this study, retrospectively identified, was about 10 pack years. The Princess Margaret group, in the same study that I referenced a few minutes ago, looked at just did Cox regression analysis to try to, and used hazard ratios, and they were able to identify different staging than what is conventional AJCC, just in a retrospective assessment, looking at outcomes for the different T and N groups, and changed the stage grouping accordingly. This works better than what I showed you in the previous slide, but there's still some bunching up in the stage 1 and stage 2 groups. They then did a recursive partitioning analysis that incorporated patient-specific factors. And I think this is a really important point to emphasize, that in this disease, it's not just about how big it is, which is what conventional staging is. It's anatomically based. This is getting us into an era, a rudimentary form of personalized medicine. It's not just about how big it is, but it's about the patient. How old is the patient? And smoking. And you can see here that when they incorporated smoking and less than or more than 20 pack years and age greater or less than 70, you very nicely now have 4 different prognostic groups in the same fashion that we like to see from other staging systems. So this may be a more robust way of identifying who is a good candidate for de-escalation and who is a good candidate for intensification. We've already heard that there are multiple de-escalation strategies. Radiation alone, we heard very nice description of some of the studies that are open for that. Maybe cetuximab instead of cisplatin. I call it seduction instead of induction, followed by reduced dose radiotherapy and minimally invasive surgery. Again, in the interest of time, we've already seen this. This is Dr. Yom's study. I think it's a fantastic effort that she's leading. The eligibility, very important to look at that. It's that favorable group. It's the small T stage, minimal N stage, minimal pack you're smoking. This would fit into the favorable group as identified from the Princess Margaret study. RTOG 1016 attempts to, this is the study that, it's actually N is 1,000. This is the study that we also saw that is asking the question, can we give a less toxic form of systemic therapy? And what I call the radiation boogeyman study, ECOG 1308. I think you and I share the same feelings about that. This is a trial that's asking the question, if we give 3 cycles of induction chemotherapy, can we get rid of 15 gray radiation? And that's a pretty, there's a little bit of chutzpah in that design, in my opinion, because in essence, there's an implicit assumption that 3 cycles of platinum, Taxol, and cetuximab is less toxic than 15 gray of radiation. And as you see here, and as you already saw, this was only reported at ASCO last year. Overall, for all comers, that platform looks to be exactly the same as what we've seen from other approaches to therapy. But is it really less toxic than 15 gray? The study, to my understanding, doesn't systematically look at that issue, and it's a single-arm study. So favorable results in this study simply mean maybe that should be studied further. And then the other question, which as we saw, is important to patients, and I think it should be important to us as physicians, is that less expensive than the incremental 15 gray that we would be getting rid of? I don't think so. Okay, so it's actually more costly. And if it's equally effective and more costly, does that make it better? Does that mean it should be adopted? And we also need to, again, put it into proper context of what happens when we give more chemotherapy, even if we give less radiation. It's almost like getting in your car and putting one foot down on the accelerator with more chemotherapy and then putting your other foot on the brake by giving less radiotherapy. I'm not sure that that's the best way to slay this dragon. And we need to remember, induction chemotherapy is very toxic, despite what the medical oncologists will tell you. Okay, well, we can give growth factors, more expensive. We can give antibiotics, more expensive. Most of them need feeding tubes. Do we really want to do that for this population? And in the DECIDE trial from the University of Chicago, which was induction followed by concurrent chemoradiation versus concurrent chemoradiation only, what gets lost in the discussion, but what is very clearly there in the paper, if you read it and pull it out, is that there was a 5% treatment-related mortality associated with the addition of induction chemotherapy. Is that acceptable to patients who have an 80 to 90% likelihood of being cured of their disease in a platform-independent fashion? I don't think so. So again, this isn't about just what can we do to reduce radiation. This is to be very thoughtful and very careful about what's going on with systemic therapy. And I will close by stating that we are also, again, seeing the reintroduction of surgery into the treatment paradigm. And I think we should not be threatened by this. We should welcome this. This is the surgical equivalent of going from parallel opposed to IMRT. Okay? It is the surgical equivalent of going from parallel opposed to IMRT. This is conformal surgery. And I think that we should applaud our surgical colleagues for studying it here in a prospective fashion. The retrospective studies that Sue showed you of TORS or translaser excision are retrospective. They're nice. They're hypothesis generating. And we now have a study going on that is, again, if we look at the eligibility criteria here, is looking at the favorable group of patients who have, according to the Princess Margaret prognostic criteria, this is a favorable group of patients who will undergo surgical therapy first. And I think this is important because at many institutions, the mission creep of chemotherapy would have thrown these people into concurrent chemoradiation paradigms from the get-go. And so this is a chance not just to dose de-escalate patients with their adjuvant radiation afterwards, but it's a chance to chemotherapy de-escalate or chemotherapy eliminate for many patients who probably don't need it either. So, to close, HPV positive and negative oropharynx cancer are different diseases with different epidemiology and prognosis. It is important, though, again, to recognize that not all HPV positive oropharynx cancer was created alike. And we are on the cusp of being able to refine how we identify different prognostic groups, and that will allow us to more intelligently de-escalate therapy, not just the radiotherapy. These are research questions. I don't think that they're ready for clinical practice yet. That does pose the dilemma to all of us of what do we do for individual patients. And yes, I'll throw out the generic, put them on a clinical trial if you can. And looking at good de-escalation strategies and good intensification strategies. Thank you.
Another very illuminating presentation, great points made. I felt that there was a lot more agreement than we normally like to see in one of these debates, but maybe that's a good thing. So maybe rather than a boxing, I should have come up with something else. But I do think a lot of excellent points were made, and I just thought you both have a 5-minute chance for rebuttal or to use that time to maybe emphasize some points, and then I thought we could open things up for questions. Maybe it'd be nice if we can leave the community with, 3 main points that we certainly agree on. I think would be nice too. I don't know if that could happen, but we could try. So,
3 main that I agree on?
You both agree on.
That
Agreement means 2 that come together.
You want us to agree?
Well, no. What I'd like to do, what I would like right now is to have your rebuttal, but maybe at the end, 3 takeaway points. Maybe they don't need to be agreements, but 3 takeaway points.
Okay. Well, Dr. Brizel confused me, and now you've totally confused me.
Good.
So much so that I had to go to the program book and pull it out and look at exactly what we were doing. It says here, debate, radiation de-escalation with HPV. Okay. So, with HPV as a proposition, and I'm going to say I have issues with several features of this title. So first of all, radiation de-escalation with HPV doesn't indicate selection for radiation de-escalation. It indicates that we're de-escalating something and HPV sort of comes along. And I want to say that, okay, I'll find some agreement here. As you saw from Dr. Brizel and me, I'll grudgingly agree with Dr. Brizel that yes, we are only talking about de-escalation in a very favorable subgroup of patients, a highly selected, clinically vetted subgroup of patients that we know has excellent outcomes with standard therapy, and by standard therapy, I mean radiation alone or the current platform of chemoradiotherapy. All right, so it's not radiation escalation with HPV, it's radiation de-escalation for HPV. The second thing I want to say is I don't even agree with the HPV. Because HPV is only offered in a few select centers where you can do the DNA analysis, et cetera, et cetera, et cetera. It's P16 that we're talking about. P16 has been validated as the national selection criteria in multiple trials. Now, are there problems with that? Are there discrepancies that will arise? Is there need for further study to select those patients better? Yes, there is. And if I could have my old slide set back up, actually, I just want to show a couple things. Can you pull that back up? My slide set from this morning. Pull that back up. We'll get back to that, okay? And the other thing I want to say is that I disagree with the whole concept of radiation de-escalation. Radiation in and of itself is considered de-escalation. So if you treat a patient, and I'm going to say right now in my current practice, I do treat patients with radiation therapy alone. If you treat patients with radiation therapy alone, as has been described in some of those studies, big series I showed you, as was done in R2G0022, you are considered to be giving less than the standard of care. And I think that's something we really have lost, maybe here. Okay, point number 2, the mission creep. I think we've lost that a little bit in terms of not regarding radiation alone as a treatment modality that is valid for clinically selected patients, which we have already clinically selected according to the NCCN guidelines and prospective R2G0022 data. All right. The last thing I wanted to say was that there are many different ways of getting to de-escalation. And this is where, again, I will admit to Dr. Brizel, I do agree with him. I sort of rejected the proposition in that sense, which is that I don't think we're just talking about radiation, and here's where we converged in our remarks. There are many different ways right now of trying to get to quote-unquote de-escalation. Some of them are real de-escalations. Some of them are de-escalations of one certain part of the program, but they're all out there and being studied. And I don't know at this point whether we've established clearly for patients or even for ourselves what those trade-offs really entail. And part of that, I'm going to lay at the feet of the medical oncology community, which is that the radiation oncology community, as we've seen with Hodgkin's, as we've seen with seminoma, as we've seen with the pediatric oncology community, is exceptionally talented at documenting the long-term side effects of our own treatment. We follow these patients out 15, 20 years. We document all the different things that happen to them from the radiation-related tissue effects. In some sense, we've been victims of our own academic success. And in medical oncology, and if there's any medical oncologists here, I'd be happy to dialogue with you about how we do that. There hasn't been the same level of study about what the effects of chemotherapy are on a patient's body at 5, 10, 20 years out, right? It just doesn't exist in the literature. You never see it. You see that patients die. You see that patients have terrible hematologic disorders. You see, abnormalities during treatment. You see that patients have acute toxicities such as feeding tubes and mucositis, but you don't see what happens to patients from intensified chemotherapy at many years out. And they have been there from the year 2000, right? So what is this really about? This is somewhat about money. If you go to any major conference, you're going to see lots of sponsors in the room, some of whom are my friends, sponsors in the room who are there to promote a certain kind of product. And some of them are promoting radiation products, some of them are promoting surgical products, some of them are promoting chemotherapy products, right? But this is really about, in the end, what funds trials, what gets put out there as the priority to enroll patients on and establishes the quote-unquote standard of care. And I just want to exhort everyone in the room here that it's not always about what the most expensive option is. De-escalation requires us to really look at what do you want from the patient's perspective, because they don't care who paid for the trial, and they don't care if the funding came from the NCI or pharmaceutical company or surgical device company or radiation company. They care about what are the tissue effects, what are the trade-offs, what's my quality of life going to look like in 10 years from now, will I be able to swallow, go out to dinner, talk to my friends, breathe when I lie down at night to sleep, right? So that's all I wanted to say. And then if you could just pull up one more thing. I wanted to point here at the very end of my talk. I have a couple of slides I wanted to show you. I am surprised that Dr. Brizel did not take us to task on what I consider one of the areas we need to make progress in. And that is what I call the widening future. So I just pulled up two examples here. This is from some really excellent work that was done by the University of Chicago. Kind of gone a little hard on the University of Chicago today, but they did a really excellent set of analyses looking at gene microarray expression. And this is just to show you that Dr. Seward and his colleagues are now proposing reclassification of head and neck cancer into multiple different types of what I would call subgroups
or phenotypes, very similar to what happened in the early days of this kind of research in breast cancer. And this hasn't been validated. This is obviously clearly in the laboratory, but I just want to think about what it would mean, not just to talk about HPV or P16 or smoking history or maybe even age, but to start talking about factors that go beyond that to things like hypoxia or angiogenesis or cell adhesion, et cetera, et cetera. And this is yet another analysis I'm just going to pull up and show you here. This is an even more comprehensive genomic analysis, multi-platform and comprehensive, that was performed by the TCGA. And as you see here, they've classified by HPV positive and HPV negative. And I can imagine 20 years from now, when I'm retired in Kauai, that there will be trials that actually select for one box in one pathway of this design. Thank you. So that was for you. I'm going to leave this up to help you.
I didn't think it was that easy to confuse you. I too, I think as people saw, my rebuttal, my presentation was a rebuttal of the title more than anything. That, again, it's not about radiation de-escalation. It's about treatment de-escalation and how do we identify those patients. And I think in terms of agreement, I would wholeheartedly endorse the notion, and I think you heard it from both of us, that there needs to be a systematic, prospective approach to the assessment of toxicity of treatment as well in these patients. We have been systematically assessing carotid artery, the development of carotid artery stenosis now for nearly 10 years, and have found that the incidence of, it's somewhat arbitrary, but we define carotid artery stenosis as significant at greater than 50%, even though that's not quite hemodynamically significant yet. It suggests that those are people who are going to need some management in the future. And to this point, we've only seen it in people who also see that risk in people who have other Framingham cardiovascular risk factors. We haven't seen it in the HPV positive patients. However, as Sue pointed out, those are younger patients and who have a much longer putative lifespan in front of them. So the fact that we haven't seen it yet doesn't mean that it doesn't exist. And I think that again, it's incumbent upon us to speak loudly. It's not just the radiation that is interacting here. We have submitted a grant to NIDCD to prospectively look at neurocognitive changes in head and neck patients after treatment. And this will be both in patients who have had radiation alone and radiation and chemotherapy. And we need to take the lead in this, because I think what we see and what we learn in terms of late toxicity will very much inform the decision and the landscape. And how we make treatment recommendations may very much be a function not just of the disease, but the patient's overall health status. And we all do that sort of with a gestalt when we see patients now, and it would be really nice if we can generate data to help us be a little bit more formal about that. The other thing that didn't come out in the ambiguity of the title, radiation de-escalation, but we've heard, is that maybe the radiation dose is just right. I mean, nobody was ever cured with chemotherapy alone. That didn't come out in our discussion. But there's lots of people that are treated with radiotherapy alone. And so the de-escalation, again, I think in many instances may be simply getting rid of systemic therapy and either going with a radiotherapy platform or a surgical platform. And I think we need to embrace the fact that for early stage disease, surgery is a great treatment for these patients. But what radiation de-escalation isn't just about the dose. It's also about the volume. What do we treat? And I think that we are now in an era where our ability to use imaging for staging has improved considerably. Our understanding of the biology of the disease is changing, and it's very clear that whether you use radiation or chemoradiation, that you don't need to treat bilateral necks for a large number of these patients. In fact, you can glean that from looking at some of the surgical literature. And many years ago, I went to a meeting in Europe, and there was a group from Germany that showed their results for surgical treatment of tonsil cancer, T1 through T3, N0 to N3. And what they showed was that until you got to the T3s and until you got to the N3s, the incidence of contralateral neck failure was less than 5%. And we're in an era now where we can make those assessments very well as to whether it's getting onto the soft palate and whether it's getting into the tongue base. And a de-escalation and reduction in morbidity can come simply from treating the ipsilateral side of the neck. You can do a much better job of sparing pharyngeal constrictor muscles. You can obviously spare parotid and submandibular glands, and we need to be very cognizant of that and not overtreat patients.
So Dr. Brizel, you're aware that in HN002 there is a control for bilateral versus unilateral volume reduction. So you know the trial actually does incorporate that. Thank you.
I know that. I think it's a great trial. There was a lot of discussion as that trial was being developed as to what to do with the N2B patients. And I still think that we need to be thoughtful about N2B, and when, as much as I think we need to quote data, but we need to always understand data from the era in which it was derived. And even in your trial, there was a large camp of investigators who wanted to mandate, if I remember, bilateral treatment for the N2B necks based on the older Princess Margaret data from 2001. Is that true?
No. We wanted great radiotherapy up front.
but yeah. Okay.
I'm trying falsely to give Dr. Brizel a hard time, but I just want to say, you know, the NRG-002 trial was the combined product of multiple committees, some of which Dr. Brizel did sit on.
My question is, the 3 different trials that are out there looking at dose escalation or treatment de-intensification, whether it be through surgery or less radiation dose or less chemotherapy, is there any standardization of the way patient-reported outcomes or toxicities are going to be scored across those trials so that we will have a chance to really look at what's better for the patient? Because it seems likely that many of these de-intensification strategies might be useful for the appropriately selected population.
I think we can both address that. I'll confine my remarks to the ECOG 3311 trial, which I was involved in the development of, which is the transoral robotic, excuse me, the transoral robotic trial. And in that study, the important facets related to your question are that all of the patients on that study will be undergoing serial swallowing studies that will help to modify barium swallows before and after treatment, that will be analyzed at a central center. And all of the surgeons on that trial have to be credentialed before they can go on, before they can start treating patients on that study. So I think we'll get some good information on the relationship between dose of postoperative radiation and swallowing function. And I don't know if you want to talk about your trial.
Yes, I do. I want to talk about my trial. Radiation de-escalation, I just want to point out there is radiation de-escalation in HN002, and there is radiation de-escalation in a large part of the surgical trials. So if you believe in any of that, you believe in radiation de-escalation efforts that are ongoing. And as a matter of fact, when the design of ECOG 3311 was going on and starting to open, which is a little bit precedent to 002, Dr. Ferris and I deliberately coordinated our PRO instruments. I think that was the question back there. And so we're using the same swallowing instruments to facilitate future comparisons. It is really important that we all start to use sort of similar instruments throughout the trials, and that effort is happening now, specifically in the HPV population, that we're trying to coordinate that better. So I just want to say, you know, there's been a lot of praise for 002, there's been a lot of praise for 3311, and those actually, I think, do both include radiation de-escalation with HPV.
They include therapeutic de-escalation, not just radiation de-escalation. Again, both of those studies, if they are positive trials, will help to, they will reduce radiation dose, but I think more importantly, they will eliminate chemotherapy dose to a large number of patients.
Yes, I just had a quick question on, is the risk period for recurrence the same for HPV positive as HPV negative patients?
Yes, I mean, to a large extent they are. You still see recurrences sooner rather than later, as opposed to diseases such as breast cancer maybe, or prostate cancer. My experience has been that the patterns of recurrence are similar. You still tend to see more local and regional recurrences than distant failures. That's been published and is pretty clear. I do think that the time to recurrence may be a little bit longer, not a lot, but a little bit. And as we saw, what clearly is different is that survival after recurrence it can be much longer.
Well, that's the issue. I think you know, there's some confusing reports out there because you know you've probably seen some of the very interesting reports that you know they recur in weird places, they get strange metastases, and I think part of that is from the fact that these are younger patients who are healthier going into it, so they're more likely to survive longer just on the face of it. And then because of that, you're seeing a more extended natural disease history than you might see with a different kind of oropharyngeal cancer patient.
You know, there was some mention about refining out the volumes as a way of de-escalating therapy, but I was wondering if either of you could touch upon adaptive radiotherapy as another potential mechanism to de-escalate therapy for oropharynx.
We have a clinical trial that's open right now at our institution that is using PET-CT simulation and then repeating PET-CT at 20 gray. What we're doing with the PET data is still a work in progress, but what we have seen is that for a lot of these patients who may have anatomically large T3 or T4 primaries or extensive nodal disease, that the disease regression is very, very fast in these patients. You can see it can be, and I said many of them. And what you can do in a situation like that is if you get a more favorable geometric relationship, separation, if you will, between your tumor, your target volumes, and an anatomic region such as the pharyngeal constrictor muscles, you may be able to replan in such a way that you can reduce the dose. I think it's nobody. Let's be honest though. People talk a lot about adaptive radiotherapy. Nobody really knows how to do adaptive radiotherapy. There are multiple ways to do it, and I think the most important thing is that you study it in a systematic way. And it's very, you got to be very careful when you do adaptive radiotherapy. I don't think we're at a point yet where we can say, well, if they're responding favorably like that, we can reduce the dose. Okay, do you adapt the dose? Do you adapt the volume? And when you adapt the volume, the principle that we are adhering to is that we still treat the same compartment, the anatomic compartments, to the same dose. It's simply if there is a concentric reduction in the size of the compartment and it's further away from a critical structure, you may be able to re-optimize your plan.
Okay, I'm just going to announce to the room, I concede the debate to Dr. Brizel. I concede the debate to Dr. Brizel because I want to emphasize that ECOG 1308, HN002, ECOG 3311 are all experimental. And so I concede the debate to Dr. Brizel on this condition, which is that we amend the proposition to radiation de-escalation with HPV as part of standard practice. Then I concede the debate.
I think we agreed on far more than we disagreed, and I would say that it's a draw.